Start. Welcome, everyone, whichever time zone you're in. Greetings to those in East Africa and Uganda. Good afternoon. Welcome to today's 119th ECHO session. My name is Rebecca Asimire, and I'll be your moderator for today's session. If you know that you have a colleague or a friend who has not yet logged in, please send them a reminder to log in as soon as possible. A couple of house rules. If you know you're logging in, please make sure that you mute your mic and your video. If you have anything burning, you have a question, a clarification, you just want to say hi, you want to share your experience, please use the chat room. One of our experts, Mr. Omar, will be handling all chat questions. And if you really want to have something burning that you want to voice, please endeavor to use the emojis, put your hand up. We'll be sure to unmute you so that you can speak to the audience. Today, our session is titled Enhancing Clinical Competency in Mass Casualty Incidents. Might be a new topic, a new set of terms for you, but I'm sure today our experts will expound on that. But mass casualty incidents are one of those very challenging situations that many EMS providers like us, like you out there, will from time to time encounter. And we shall see it does pose an extraordinary demand on our system and resources. And we do need a particular set of skills that goes just beyond medical knowledge to be able to deal with a mass casualty incident. And today we have quite an experienced panel of experts who are going to introduce themselves. I will start with our expert on my left.
Thank you very much, Rebecca, for inviting me to this session. And thank you very much to Global Health and Ministry of Health. It's always a pleasure to be part of this movement where we try to share the knowledge we have and also learn, because through the chat, we surely get to learn a lot from you as well. So thank you very much, and I'm glad to be here. I'm Dr. Daniel Olinga, an emergency medicine physician and a lecturer from Barry University of Science and Technology.
Thank you very much. Good afternoon, those in East Africa. Daniel Osuga is my name. I work with the St. John Ambulance, man EMT, and I've been delivering trainings in a number of pre-hospital courses. Nice to be here.
Good afternoon, ladies and gentlemen. Tambi Umar is my name. With the Association of Ambulance Professionals Uganda, I am an instructor in the EMS field, and I am humbled to be here. Thumbs up to Seed Global. We are very proud for these wonderful sessions. It means a lot. We are proud for the full support we really also have from the Ministry of Health, and very proud to the EMS family for the entire African continent that to make a difference. Glad to be part of this session.
Right. So at this point, there'll be pre-test questions that are going to be launched any minute from now. Please do fill in those pre-test questions. They're quite pertinent to your learning and experience in today's session. Now, again, at this point, I'd like to invite any members out there, please, you can unmute or put your hand up to give us a bit about your expectations for today's sessions, what your expectations are, and if you have any questions for our panel of experts before we dive into today's session. The poll questions have been launched, pre-session poll questions. Please endeavor to fill in, to answer or attempt to answer the poll questions. And if you'd like to unmute and share with us your expectations for today's session, that would be great. Okiror. Okiror, Andrew Okiror, your hand is up.
Yes, thank you so much. I hope I'm clear, and I'm really glad I see the experts. They are more experienced and they have handled quite a lot of these emergencies, especially responding to those disasters and those catastrophes and so on. Me, what I would just want to hear from them, my expectation is from their experiences, how they've really managed to cope, their coping strategies whenever they are dealing with these challenging environments in the EMS response in Uganda. Thank you.
Thank you so much, Andrew, for that. How do they cope when dealing with these MCI incidents? Anybody else out there? You can just use the emoji, put your hand up. We'll be able to see it and unmute. I see Abang Christine. Hello, Abang Christine, wherever you're joining in from. Abang Christine. Oh, someone has said to get more knowledge on how to respond on massive RTAs. That is Charles Kana. His objective is to get more knowledge on how to deal with MCIs such as a massive RTA. Anybody else? I hope we are attempting the poll questions. You can use the chat. Odandu Joseph, I think the audio is on. Maybe you want to check that again. I can see that you're putting the chat that you're waiting for audio. It should be up and active. Kayongo Michael says how to triage in massive RTA and ensure all are attended to. I'm sure our experts are going to delve into that. Thank you very much, Kayongo Michael. All right. That's good to know, Joseph. Right. All right. Biachika Peterson. How well to allocate available resources to casualties and minimize mortality. Interesting. Odando Joseph says, what qualifies to be an MCI incident? Interesting. I'm sure our experts are going to expound on all of that. Kayondo Allen says, I have a question about CPD points. The link shall be shared in due course of the session, so watch out for the link. You'll be able to use the link and register for your CPD points. Thank you, Kayondo. Once again, I hope you are all attempting the poll questions. What does Sandy Friend Opeli? What does did you mean ME or MW? But I think you meant ME, methane stand for. Yes. Thank you, Charles. What does methane stand for? Natukunda, Kato Baram, your hand is up. You are unmuted you are unmuted. You can now speak. Kato Baram. Kato Baram?
Yes.
Yes.
Yes,
Thank you. Yes, hi, Kato Baram.
Yes, hi. Good afternoon, members, and good afternoon, participants. My question is, we are many in the line of medical field, and many of our colleagues are deep in villages. And the issue, yes, I appreciate the issue of CPDs, but then we have a challenge of networks being in lower facilities where network is too poor. So I feel though the system is good, but seems not to be balanced on either sides of the medical health fields.
All right. Thank you, Kato Baram. That has been noted. Thank you. Peter Chitibwa says, what can a health worker do when they feel helpless in MCI situations? I think we have all gone through that. If Masudi Lutaya says, effectively manage mass casualties with minimal loss of life. And then Kathleen Orix, his expectation is more light on methane as far as MCI is concerned. Okay, so the poll questions have been closed. And it's at this point, thank you all for attempting the poll questions. And at this point, I'd like to welcome our first presenter of today's session, Dr. Daniel. Over to you.
Once again, thank you very much, Rebecca, and to all the audience for logging in. And as we get into this topic of great concern, from July 7th to July 16th, Uganda as a nation has had a dark July for a month. So these bloody 10 days, as stated, spanning from Omoro through Mukono, Bale Iganga Highway, to recently Kapchora, where we lost a number of lives. As the audience, as the panelists, we stand with the family members and we take a moment of silence, pray for the departed souls. And may the souls of the departed rest in eternal peace. Amen. All right, so we coined this, and the highlight from July is that we had road traffic accidents. Today's topic goes beyond road traffic accidents, because the mass casualty can involve bulldozer, mudslides. We again lost a couple of people there. It could also involve other natural disasters like flooding. I know panelists here, Umaru, Daniel, were part of the team that actually were taken down south to try and curb the worsening situation. It could be a fire outbreak in a market, building collapsing, and so forth. And so today, we say, not another bus, please. We shall discuss all things mass casualty. And we hope that this, to you deep down in that health center 3, will have a clue to prepare for that next incident that could potentially happen. Because we have to be prepared as a nation. And so for the next few minutes, allow my voice indulge you. You can get a plate of biryani, get some corn, renzori, and we shall do all things mass casualty incident. And our roadmap today, we shall quite define a few terms here and there. We shall look into the resource constraints. I think in the chat, people were saying, how am I going to handle this in a health center 2, potentially? That feeds into how we communicate which my colleagues will also delve into better, into the Ugandan structure, the different referral pathways, and documentation of these events once they occur. And so the quick question will always be, what is a mass casualty incident? And broadly, it's really an event in which the number and the severity of casualties exceed. So the number of casualties exceed the immediate available medical resources. So the marking points there, the number of casualties are exceeding the available medical resources and the capacity to manage them routinely. Case in point, you have your medical center, 2-bed resuscitation room, and you're prepared for 2 patients at least in every 24 hours. And now there's a taxi that is just in front of your health center with 14 individuals. They're coming in and they need all the resources of the 2 and more for you to actually give them the best care that you can. So resource capacity there is then exceeded. Sometimes it's not necessarily the patient count, because if that then happens in a facility that is well equipped, or that is even a next of kin or Mulago National Referral, you can mobilize some of the things quickly. But are the resources enough to actually handle these casualties that have come into your facility? And that's what a mass casualty incident is. Number of patients exceeding the available resources to be used. And so we try to scale it down and relate to the different levels. So there are commonly 3 levels that are used. Level 1 is the simple one. So the demand can be met by the local resources. So you have a health center 3, potentially gynecologists, midwife, and other doctors in there. You can mobilize some of the beds and say, okay, we're in accident and emergency, but then OBS-GYN can also give us more suture material if the patients, for instance, have gotten a road traffic accident. So you can mobilize that, and that becomes simple, could locally be held within that facility. The next level is regional, really, and we could also term it as the compound mass casualty incident. So the local resources and infrastructure are overwhelmed. You had one hospital, case in point, Jinja Regional Referral Hospital, but the resources there cannot handle the bus crash that had 67 casualties coming in. And so you have to activate other nearby hospitals, Kawolo, you can go as far as knocking at the doors of Mukono, because it's within that region, but you need to expand to try and curb that mass casualty. And then the national level are these catastrophic events that knock on the doors of Ministry of Health and even different NGOs and say, hey, now we are overwhelmed. We need to set up even camps and mini hospitals in certain areas because patients continue to trickle in. So you're even having hospitals damaged. In our setting, case in point was in Kasese. The floods came and swept away even the health facility. So the patients were running towards the health center 3, and they said, yee, again, the health center 3 has gone, okay? So that is where now we activate the national and also international agencies like Red Cross, Red Crescent to come and try and curb these facilities. So I'm painting a picture of how big or the magnitude this could actually be. And so as we get into the understanding of what an MCI, so we are going to use the word MCI for mass casualty incidents so that I don't keep, mentioning these phrases as a full sentence. We are going to compare this with what do we do routinely in our practice. So the focus in the routine practice in Dr. Jimmy's hospital, he wants to see this patient, try to do the best that he can for this patient. He's going to ask for the CBC, grouping cross matching, CT scan is activated because I want my patients to get better. It's the focus. So one patient, try to clear them up. While in an MCI, we want to do this for a group of people. So the best possible outcome should be achieved. As opposed to one, we are looking at 50 people. How are we going to salvage these individuals? Because as you look at them, as you walk in as a health worker, at that point in time, you're not even going to recognize that this is a minister of MCI, even, say, for instance. There could be a nurse, there could be a head teacher. So there are very many, and all these people are important in all ways. So it's a group of individuals. In terms of resources, again, in our routine care, essentially one patient still. Can we channel all our effort to this patient? The other side, we are trying to rationalize and prioritize. So if you said in a routine care, patient came in with a femur fracture or the spleen is ruptured, activate massive transfusion protocol. So you're bringing there 4 units, you're bringing platelets for this one patient. At the MCI arm, we are saying, we are having actually 6 patients here who all desire blood. So let's give one unit as we organize them to be transported to their facilities. So that is how we try to rationalize. Then the speed or the decision making. So here we have a deliberate effort. I want to come down to the actual diagnosis. So from the anther to the stigma of the same flower, self-pollination. So in the routine care, you're doing one patient, you're going to do everything. But here in MCI, we are trying to be very fast. We have protocols that we work with, and we try to distribute this across the casualties that have been involved in this particular MCI. It could be a road traffic accident, natural disaster, fire outbreaks, building collapsing. And so we ask the questions on 2 arms. So for the routine clinical care, we say, what is the best for this patient? Then I emphasize an individual. And on the MCI part, what is the best we can do for the most of the people? And we choose the word selectively. While we use best here, we are saying most good. Most good. So best is better than good. So we're using the most good, what we can at that very point in time. And so there are very many pillars people can always try to bring when we're trying to discuss MCI. But it's always nice to put them into a hand. The hand has 5 fingers so that you can easily carry them. So we shall delve into this simple structure, and that is understanding bits and pieces of the triage in MCI, resource prioritization, clinical decision making, which is very key. This one, me, I am very, I don't know, but yeah, I'm very keen on clinical decision making and communication. Also very, very serious matters that we shall discuss, then eventually referral pathways. So let's look into this, starting with the triage. So triage is really a process of sorting and prioritizing according to need. And so here, our purpose is to rapidly identify who needs care first and directing, underlying our limited resources to those who are most likely to benefit from it. In one of the movies I watched, there was a patient who was even tagged black. He was, I think, buried in cement. I don't know if it was resident or something, but one of the actors now was so enthusiastic about this person. He brought in IV drips, brought in blood, and even brought a ventilator to support this patient who was buried in concrete. I know that is really wasting resources, but that is the movie, and that's why we are here to try and say, as we learn more about MCI, our goal is to allocate the limited resources to those who are most likely to benefit as fast as possible. And so 4 things are involved. Speed. Here we are taking seconds per casualty. The more we do the drills, the more we learn tabletops and etc., we actually get to know that this can be done as fast as possible, as opposed to the minutes to hours that we usually want to take in triaging this patient. And as you will see the tools that we use in the next slides, we ensure simplicity. Let's go back quickly. So we ensure that simplicity. So the steps should be very few. There should be clear decision-making points. And so for you to actually harmonize that I understand triage in a mass casualty event, you actually have to be trained. And this is one step to that. So let's get trained. Let's try to understand some of these concepts. They may look ambiguous, but the more we get trained, the more we do the drills, they become simple. And so simplicity is the word we preach. So repeatability or reproducibility. So the same casualty should be assessed by the different respondent in the same manner. If Umaru comes and says this is yellow, I should be able to come and say this is yellow and not orange, because another person will say but. The moment you say but, you're seeing yellow, orange or purple. We should stick to the same principles. And then we also know that while triaging, most importantly, the triage category or prioritizations of these patients changes. So you may have tried about 5 minutes ago or 10 minutes ago. So when you come back, this now becomes from yellow, becomes a red patient, right? So let's look at some of the tools that we use to triage these patients. And the first tool I'm going to take you through is the START. START, which is an abbreviation for simple triage, and R, rapid, T, treatment. So simple triage and rapid treatment. It is a universally accepted algorithm that we go through to try and harmonize the understanding of how to prioritize these patients. And so the first and the easiest, as we set up our tents, etc., police are cordoning off the area, the ambulance crews are setting up, we say, are you able to walk? If the answer is yes, so immediately we label that as green and we send them to the green area. So in that green area, retriage can actually occur. Retriage can actually occur. And if they're not able to walk, we go to the respiration. I'll give you a better structure, but let's just understand these breaks here. So we go to the respiration, which is, yes, breathing, especially after airway repositioning. So if you reposition the airway and the patient is still not breathing, or the apnea, such breath, so you label this patient as black triage code, that is diseased or expectant. But if this patient is breathing, so the next question we ask is, what is the respiratory rate? So quick one, don't remain there counting the number of chapatis that the Rolex guy is making. Let's use the first 15 seconds to count and multiply by 4. So you will get an approximate figure. If it's greater than 30 minutes, 30 breaths per minute, then that is immediately a red. If it's less than that, we move on to the next. That is circulation. So we look at the capillary field. Is it raised or no? So if it is raised greater than 2 seconds, that is a red. If it is less than 2 seconds, there are two things involved. We again ask, can they follow command? Yes or no? So if they can follow command, what is your name? And he responds appropriately, that is a yellow or delayed. Then if they cannot respond to command, it becomes red. So now let's move on to the one that we all like, that's the factor tree. We did mathematics, and there's a way they always drop down those things, they appear lucrative. So that one is the one people really like. So green, we have already put it on their side there. They have gone to our tent and they are already walking. So we call them the walking wounded. I'll give you a summary of these terminologies. We said respiration, yes or no. So if it is no, we position the airway. Once that airway is opened and the patient shows you signs of breathing, tag him as red. But if you position the airway, I mean these maneuvers of head tilt, chin lift, and for trauma jaw thrust to open it, the patient is not showing any signs of chest rise, no, that is diseased or expectant. So enjoy that. And so on the other arm, it is, I hope everyone can hear me. I'm using French. And so if the respirations are present, yes, so we say over 30 breaths per minute, that is immediate. If it is under, we go to perfusion or circulation. And here we're asking, is the radial pulse present or absent? And so we also look out for the capillary fill most especially. So if it is over 2 seconds and we are seeing evidence of bleeding, so we want to control bleeding, but we tag that patient as red. It is less than 2 seconds, mental status, again for spaced repetition. If the casualty can follow the simple commands, it's yellow. And if the casualty cannot, then it becomes red. And so that is the start triage, simple triage and rapid treatment that we can employ when these mass casualties have occurred. Alternatively, there is another format of triage that we can employ. And this one, I love it because it works for large numbers, right? And so there was a scenario, I think, in an airport in the UK one time. There was some form of incident that had occurred, explosion of the engine, but they did a crash landing just near the airport. And so the EMS team came in and wow, it was a Boeing 375, I think very many patients, over 300 people were inside their casualties. And so for the SALT triage, what these individuals, the paramedics then did was to walk into that room and they picked up a megaphone and said, okay, if you can hear me, may all of you raise your hands, okay? So a sea of hands just went up, over 200 hands, and you know these are already 300. So one person can actually get stuck. But then, because of that global command, they said, now, for those who have neighbors who have not raised their hands, please keep your hands up. What does that mean? So all the hands, most of the hands went down, but now you're having a neighbor who is very sick. So now they can actually identify that, oh, so these 10 people who have left their hands up have someone who is not able to actually communicate with us by raising their hands or by, talking something. So its SALT is sort, assess, life-saving interventions, treatment, and transport. And so we start with the global voice to actually identify those people, one who can walk, those who have some purposeful movements. You can say, wave at me, so that you know that the patient can actually obey command, but is also able to actually move their limbs. And those who cannot show movement grossly. And then after that, so we then quickly assess them and identify the life-threatening conditions. If there is catastrophic bleeding or major hemorrhage, we make sure we tourniquet. If there is a pneumothorax, we also decompress that. Then once we have those ones, we finally assign them their categories as immediate, delayed, and then start transporting them to the designated facilities. So SALT versus START, people will always have a debate about this. Use what is comfortable and what you have been trained with. Don't say I've been trained in START, Dr. Linga mentioned SALT, then tomorrow you're using SALT. You might end up getting the chumbi for food instead. So let's focus on the major events, right? So then I've been mentioning lots of words here, and people are going to ask questions in chat. Dr. Linga, you've been saying expectant, then you mentioned black. So let's just put this into context. Red, the red casualty patient we are tagged on triage. This is a patient who had life-threatening events, but he can survive from those injuries. So he needs our care within minutes. So put them in an ambulance, ship them very fast. If you can tourniquet, do that. And then the yellow patient, delayed, has some serious injuries, maybe fracture of the hand and is really shouting at you and etc. But it can wait. She has not gone into the major artery. Say, for instance, around the humerus here, it could actually sever the axillary artery. You need to delineate. Those can wait for hours without you intervening. Then the green patient, those ones, Umar actually loves them. The walking wounded, they're the ones even who are able to tell you the story. They're confusing the health worker. This is my sister, that is my judge. Green, send them to the green tent, but when you're reassessing them, others could be making a lot of noise and then they just drop. So you retriage them to yellow or red. And then black, the expectant or disease, we have seen their injuries are incompatible with survival. So this is a patient, you've seen him there, he's still opening his eyes. You ask him, Sevoliocha, the brain is missing. So the skull is open, he has left the brain maybe in the bus, for him he has been ejected out. So you cannot bring back the brain to make this, you understand, unless there's a brain transfer. So we continue doing this, and especially as you're triaging, you're not triaging just to put those color codes. Like we shall see that there are teams, there's a team that is going to be put together. You have to do resource prioritization. Always keep these things at the reach of your hand. So these ones are 4. So match the triage category as you're trying to prioritize these patients. Okay, so equipment, personnel, and the transport. I'm happy with our EMS system nowadays. As we are developing most of these protocols, they are also prioritizing the ambulances. We have type A, B, and C. So as you're triaging, please, if a patient needs a ventilator, then again, you're reversing a type A ambulance. It would not make sense into matching the triage category. But if the patient, for instance, is red and needs respiratory support, you're already thinking a type C ambulance. You might end up intubating them and then you need a ventilator. Then let's use the scarce resources according to the protocols. Just like the example I gave earlier. You may want to transfuse this one patient, massive transfusion protocol, but here now we have to try and utilize for all the patients that are there, but also improvise. The EMS team could have come with 5 tourniquets and you're having 10 patients who are bleeding out. Will you say, okay, we have 5, let's first tie one person for 5 minutes, then we remove, we run to the other person? No, we would rather get some appliances that could actually mimic the tourniquet. All together. So you can get like a giving set and it's a strong rubber and rotate it around. It would achieve some form of hemostasis until the patient is transferred. I emphasize reassess and then reallocate. As the triage color changes, the prioritization of these patients and the resources that they need also changes. And then we have to always activate the surge capacity. And what is that? We have to activate surge capacity. And surge capacity really is the ability of the system to quickly expand to accommodate the casualties that have come to the hospital. What do I mean? So Health Center 4, for instance, has a theater, has obs-gyn, surgery, all are functioning. This time they have flocked into the accident and emergency setting. So the idea of understanding surge capacity is by me telling you is we are going to deactivate the non-essential parameters in the hospital. So we are saying, okay, obs-gyn, let's stop doing the electives and focus on coming to achieving what? Hemostasis. So we have deactivated the elective arm so that we recruit more capacity to actually handle these trauma patients. So the word or the phrase there is surge capacity, which is the ability to expand, but behind it, it is telling us we have to deactivate. OPD, you're having very many doctors there sitting. Honorable Balam has actually been unearthing them recently. They are seated in OPD seriously, treating cough flu. But now a mass casualty has occurred. You say, excuse me, you did MDCHB, you know how to achieve hemostasis. Close OPD, come with the A&E. That is really activation of surge capacity. In all that we are doing, ethics is very important because we want to do the greatest good for the greatest number of people. It has been unanimously celebrated in our country that sometimes ethics is not applied. Patient really needs ICU, but in the same event, now you've identified that Dr. Linga is in the picture. Remember, Dr. Linga just has a torn lip. You can even afford plastic surgery in the future, but you've already booked an ICU bed for him. And there's a patient who needs it. Are we doing the greatest good for the greatest number? So that is why we are training or teaching you about the process of being fair. And that is how this start and salt come in, so that you're more realistic and idealistic in how you are handling this issue. So it comes with the transparency really, and how you will apply this more consistently. So like I said, what Umaru should be able to do, I should also be able to do. Do not discriminate. We have this tendency, because now someone is on a suit, you've seen a Dolce and Gabbana bag, you're running to that person because the person might wake up and say, V8, you saved my life. No, we are in a mass casualty, and we can actually save all these people if we apply these. And like we shall see in the next presentation, it is clearly elaborated with the CTAS and many tools that we're having. And so adapting a good clinical judgment actually makes you have effective clinical decision making. And so from time to time, you have to engage with your protocols so that you have them in hand and you should know them. And for most of the part, the team leads should actually know these protocols. And these protocols are international, but like we have said, what could be happening in another country is not happening in Uganda. So we tailor our triage protocols to our society. That's where EMS in Uganda actually comes in. We also need to do continuous re-triaging of these patients. Triage as we are moving on. So yellow becomes red, treat them, send to the nearest facility according to the need that is desired in that place. Then we also have to recognize decision fatigue. So a commander, incident commander could be overwhelmed at this point, is receiving very many phone calls here and there, and now he starts making wrong decisions. And that really happens. Sometimes people just stand in the tent and they just say, Umaru, take that one. Where are we taking them, Mulango? Take the other one. You're no longer doing the accurate, triage. Why? Because you're fatiguing. It's not that you don't know what you're doing, but you're fatigued. Let's be able to recognize that and share responsibility. It doesn't degrade you as a minister of health or emergency physician. It's that you're tired and you're bound to make more mistakes. And then senior oversight is very key. There are people who have done this over and over again. And so it's important to activate them, and they should be making the final appropriate calls. And remember, across the deck, this is really a team-based judgment. You could be activating Kaolo, and yet Kaolo doesn't have some essential resources like a neurosurgeon. So you have to tailor, and the team members can actually say, no, we know that this other hospital has CT scans, neurosurgeon, so we better transport some of these patients to that area. And all this is a process that you keep documenting and revisiting, because you have timeouts where decision makers just have a quick check-in. Where are we at right now? Next slide. All right, so this is going to be highlighted and also made better into our EMS system by Daniel. But communication and coordination, this starts all the way from the incident commander, is the overall authority of the scene. And it's highlighted red there because it's the most important part, but also the most confused part, because it tends to have very many egos starting to fight in that place. You've identified the incident commander, most likely or most commonly the person who has dealt with this many a times, has enough experience, enough training, he's doing his role. But because he is a medical officer, a big gentleman comes sitting in a state house and says, no, now I'm the one taking charge. Bring the helicopters from the military, bring this. So now we start having conflicts already, because we're starting to have very many incident commanders. And that's why I love the healthcare fraternity. It humbles you at a certain point, and you realize that the people who are even trying to inflict on the decisions that the selected incident commander is making don't know what salt or stat is. So now, anyway, so incident commander, overall authority in the scene. But this breaks down to the medical arm as well. So you have a medical lead who will be on ground, who will be reporting to the incident commander of what has been going on. So again, this could be an emergency physician, could be a senior paramedic. They are down, medical branch. But under him are now a branch of other officials. So you have triage officers, you have treatment officers, and then the transport officers. This is a simple scale out, because there's a bigger structure to this, but it's just a simple scale out of how we feed communication back into the incident commander. And we shall answer who the incident commander can be in the next demonstration or presentation. Communication is very key as we wind up with this session. So we should use a language that is familiar to everyone. Let's try to keep it as plain as possible. For example, I always communicate with Umaru, umbrella, delta, kilo. But we might get into this place. We have gone to Amolatar deep down there, and Umaru shouts umbrella. So you end up seeing health workers running to pick umbrellas, and they will come with umbrellas. But it's because we are missing a certain form of what? Communication. So let's use words that are common to everyone. So plain language. We have gotten a road traffic accident. We are going to triage the most sick patients as red. So when Umar says, all red patients, pandeile, hey, they know that it's red patients, not radio. So radio upper. People are going to bring radio cassettes from there. Parents. And then we also want to use some known acronyms or mnemonics. These are worldwide, really known. And people were asking what methane could be, ISBA, handover reports. So we're going to talk more about methane, which is the major incident. You have to declare it, exact location type, hazards, access and egress, number of casualties and emergencies. Every time you're declaring an emergency mass casualty incident, methane has to come out fast and clearly. I'm not going to emphasize that enough. So in all that you do, as you're going back to sleep today, write it on the ceiling board, because nowadays builders know how to actually structure this out. So write methane, and it just gets into your mind. And we want to avoid redundant channels as well that may actually misinform masses and result into break of communication. So you find that a mass casualty has occurred. So different media flocking in, you're trying to communicate through the right channels. Before you know it, Dr. Rebecca is first holding a press conference with other people on the other side, mentioning whatever. Umaru is this side. So you're going to have mixed communication, and you're going to activate different sites to come and help. And yet all this, if you fed this information to the incident commander, is then able to create a certain channel of communication that is understood by everyone in or responding and everyone out. So internally and externally should be tailored to one place. And then regular check-ins, situational reports should actually be coming out regularly. Initially we had reported we had 24 casualties, 6 of those have ended up in Mbale Regional Referral, others are on their way to Jinja, but now the number has increased to 48. We need to know this, because then it helps Tororo say, our ambulance driver is if it's a Friday night, the man is in, let's get him out and drives to support the team on ground. So those are key elements that you need to actually have during communication. So methane, take a screenshot, print it out, marinate it, put it in a portrait. Here we go. M, major incident declared. So confirm if that major incident has occurred. We are having a burning building right here in Kalewe, major incident. You need to declare it as much as you can. And you have to say the exact location. Be precise. I'm around the Ntinda Bukoto now. So I might come from the other side of UNEB, thinking that is where you are. But be precise, okay? I'm near Friend Supermarket. At least everyone can say that, okay, this is the highway. I know that this is near the lights, and I will come there. If you have a GPS coordinate, you can actually forward it as well. The police can use that and then locate you precisely. That is E. And then T is the type of incident. E.g., it's a road traffic collision. It could be a building that has collapsed. We're having a fire outbreak, that is type of incident. And then H is for hazard. What are even the potential hazards should be mentioned. So the present hazards, so there is an active burning building right now. So there's fire in the picture, but we're having petrol flowing aside, we're having debris, we're having chemicals. All those are potential because it can cascade. Just imagine Chengera gets an explosion in one place, my friend. You can get a community of petrol stations there, together in the band. So you have to mention all those potential. Then the most important one, again, is the access. How can we access where your event is occurring, and how can we exit? So you have to confirm this clearly, because that is how the EMS team, the police, the fire brigade will have to get in and also take out the casualties. Then emphasize on the number of casualties. Remember, from our definition, we say number of casualties exceeding the available resources. But if you tell us the number of those casualties, we look at the resources and we start prioritizing. If it is time to actually activate other centers to actually support us and give us more resources, that number would be the one to inform. So the estimated number of patients or casualties. And then what other emergency services do you have? So currently we're having one ambulance and then there's a police pickup, right? So now if you mention that, you also tell us further what you could be needing, right? We could need fire brigade to put off the fire, could need more ambulances, need more health workers, you know? So this is where the emergency services also comes in, and that is the methane reports that you get. So very many scenarios that you will come across, try to just write it out. The more you practice it, the easier it gets. And so let's talk about briefly the referral pathways that are involved during an MCI. So from the scene to definitive care. We have talked about triaging these patients and tagging them. So we have to actually look at the load balance across the facilities, looking at what is the nearest facility, but also what do they have to offer. Because you may be packing a health center with very many patients who are needing plastics because maybe of severe burns or needing neurosurgeons, and yet this is not the correct or ideal way of approaching this matter. So triage tagging, casualty collection points should be clearly there. So like I told you earlier, for instance, green, you say, this is their tent. Red, you say, this is there. So that when even the health workers are coming to pick them, the transport officers that are located, it's easy for them to actually get to that place and say, we are picking off these red patients. And as you're removing them, you'll actually see that the numbers are decreasing. If there are still many, you still activate other facilities. And we have a big challenge, receiving facility notification. Many a times an incident occurs, you only see ambulances coming. Then that's when the hospital director is told, oh, by the way, an accident occurred. So they are not aware, they cannot deactivate other facilities because now you were trying to do a hysterectomy, total, you're on table. You had not told these people, but a few minutes ago, they had not even given anesthesia to this patient. You could have cancelled such. So let's get into the culture of immediately activating the receiving hospital facilities, all right? And then definitive care, of course, should be given unto these patients. I beg your pardon for the quality of this picture, but again, just reflecting on what recently occurred. As we discussed, let's not think the MCI events or the mass casualty events are far from us. They're as close as it gets. And this is what happened in Kapchora, where the death toll rose 23, 24. That was their number. And so this is a case scenario then that I wanted to share with us. Next slide. I wanted to share with us this case scenario of a recent Ugandan tragedy again of King David Jr. school bus crash. So a school bus that was returning from an educational trip from CP Falls, it veers off, and 23 lives are claimed in that event. And imagine this is 300 kilometers away from Kampala. And so why this case? Why now? So yes, it was a single incident, but it occurred in a rural setting where we mostly have, I think the highest level is a health center for. Was it even close? No. Could be the closest was a health center 3. And so the resource capacity was overwhelmed because some of these pupils actually ended up even in Kampala hospitals. So that already tells you this was an MCI. The casualties needed rapid triage and distribution across the facilities around the region. We ask the question, was this actually done in a timely manner? So it's a case for you to really reflect on what was going on. Because following all the teaching that I have been giving you, this is not what I am telling you, the reality that was on ground. And so, again, it was a remote location occurring in the late hours of the evening or the night. Communication could have been strained. There were no clear access or referral pathways. But here we are today trying to discuss this, because when the next happens, at least we have the basics for which we can actually start from. Okay. And so, what has our government taken so far in response to actually this? Because this fits into our discussion, I will re-echo them. So there's been a nationwide suspension of these trips. That is very clear, because now if we're not trying to follow the guidelines, we are likely, imagine in a space of 10 days, we're already having 4 events occurring. So we need to have this suspended. Thank the ministry for actually doing that as quick as possible. Our vehicles should be mandatorily inspected. Again, this was pronounced very clearly. Driver clearances should be done. No, some schools were hiring drivers. The man drove his global bus from Barra to Kampala twice. Then you're now telling him now you're taking these patients to Soroti. Again, clearance needs to be very clear, and that comes with tight approvals that the ministry is trying to put in place. And then respecting the school buses as well. But how do I identify that this is a school bus? Now designation of colors is coming clearly. I think it would be a yellow bus for the school trip, especially. And then interministerial committees, then I'm happy progress is ongoing for us to develop an MCI protocol for the nation. Trainings, drills are also ongoing. So we are in the right trajectory to actually be able to respond to the next MCI. Some of the common challenges and the pitfalls that we face is communication breakdown. And here I highlight the first part, and that is the competing channels. You've chosen your incident commander, is trying to communicate clearly. RCC, because he wants to appear relevant. He's also, I'm not attacking them directly, but these are things that are happening. RCC is also communicating seriously to a different channel. So before you know it, we have a disorganized approach to our MCI. So communication breakdown. We need to strengthen communication, and we need to respect the channels of communication. People trained to do this or to respond this for a reason. You're trained to give us security for a reason. So let's respect the different fraternities that come in there. Then there's this hulabaloo about triage. So there could be over triage, under triage. Again, that is why we emphasize on using the tools that are commonly known to everyone, but also emphasizing re-triage, right? And then resource hoarding is another challenge that we face. So sister keeps specific gloves for a specific doctor. Oh, Dr. Jim is coming. Gloves, we have gloves, they are here. Dr. Linga is coming, we don't have, we are freshly out of gloves. Please, it is an MCI. It could be anyone else. So let's try to avail these resources. Once they are done, the country, the nation knows best that we need to replenish the used resources. Okay, so let's not hoard them for the future. Some of the things are even expiring because you're waiting for Dr. Jimmy, right? Then poor scene coordination, we are going to highlight this again. Identification on who the team leads would be, incident commander, medical team lead, and then the different leads for triage, treatment, and transportation. So these are areas where there are common pitfalls, and once it starts to break, when the strength in that chain is broken, everything goes down inappropriately. So my important part is the key takeaways now as I come to an end. So for triage, speed and simplicity, something that is reproducible, is what we actually want to employ, and it will save lives. Perfection is never a goal when it comes to an MCI. We can always perfect this later, but we want to save more lives as much as we can with the limited resources that we have. Then resource decision flow is also a principle that we need to highlight. And this comes with transparency. Let's not hoard some resources. Let's not say, okay, since Bara General Referral Hospital has taken up these patients, Masaka continues regularly and yet Bara is getting overwhelmed. Because of such capacity, we can actually employ other hospitals to just improve on working together. Communication is the strongest backbone in an MCI. Go through one familiar channel that can give information to the rest, because this is the structure for which our response actually stands. And then referral pathways must be clear and have a balance of facilities across the region. If you've activated one and you've sent 10 patients into that area, and potentially all of them need theater, ask yourself, do I have 10 theater beds in that hospital really? And you reprioritize and say, maybe 4 can be taken to another health facility. MCI response is a skill. It is not a one-day thing. Even us seated here, delivering this knowledge to you, we are subjected to drills time and time again. And you'll reach a certain point as you're trying to make a methane report and you'll be like, what is P in methane? And yet there is no P, but it's because you need repeated drills, okay? So drills, review, and then practice. We've talked about the START algorithm. It looks so ambiguous to me, but the second time you read it, it becomes clear. You now know that, okay, when the patient is not breathing, open airway, this one is not dead, black. Tomorrow you will add on another thing. You know that, okay, mental state, yellow. So this is how we do it. Thank you very much, ladies and gentlemen. And we can now move on to discussions. And thank you, Rebecca.
Thank you very much, Dr. Olinga, for your insightful and in-depth presentation. We really tried to give clear explanations and try to contextualize your practical examples to our local context here to try and help unpack this very quite complex topic we have today. I can see from the chat, Amanire, if I get it right, Amanire Julia says that this is a very nice presentation, very insightful, says he recently watched a movie called The Pit, and all this stuff is being shown, but clarity is being well aligned with his presentation, and he thanks the team for thinking about this. So at this point, we are going to launch a couple of questions for you to attempt and fill in. Just a couple of questions, simple, not so difficult. And I'm sure if you are paying attention to Dr. Olinga's presentation, it won't be so hard for you. Yes. The poll questions have been launched. So question one, case one, 9 people in a taxi from Jinja crashed in Marira Forest at 5 a.m. 2 kilometers away from the scene is a traffic checkpoint, Kawolo General Hospital. It's about 17 kilometers, and Jinja Regional Referral Hospital is 28 kilometers away, respectively. Fortunately, you and a colleague reached the scene in an ambulance within 3 minutes. Amongst the casualties is a driver, 23-year-old male, unconscious, no pulse, with no chest rise, has a deformed upper limb. What triage color and code will you assign to this patient? If you are paying attention to Dr. Olinga's presentation, you should be knowing the answer to that. Case one. I'll go to the next question. Yeah. Next question. So what triage color code will you assign to this patient? I remember at the start of this session, one of your expectations was to learn how to attach or assign a correct triage code. So in this particular patient scenario, you have a casualty, is a 23-year-old male, is unconscious with no pulse, no chest rise, has a deformed upper limb. What triage color code will you assign this patient? Okay, lots of you are saying black. Lots of you are saying black. The blacks have it. Are the blacks correct? We shall see in a few. So we go to the next case. Case 2. 9 people in a taxi from Ginger crashed in Mabera Forest at 5 a.m. That's 2 kilometers away. Sorry about that. Case 2. 9 people in a taxi from Ginger crashed in Mabera Forest at 5 a.m. 2 kilometers away from the scene is a traffic checkpoint. Kawolo Hospital, General Hospital is 17 kilometers away, and Ginger is 28 kilometers away from the scene. Fortunately, you and a colleague reached that scene in an ambulance within 3 minutes. Amongst the casualties is a 60-year-old male. He's responsive to pain. His respiratory rate is 29 minutes. His temperature is 35.8. He has a bruise on the scalp and is complaining of neck pain. What triage code will you assign this patient? Okay. So the next hospital, Ginger is 28 kilometers away, Kawono is 17 kilometers away, but you find a 60-year-old male who is responsive to pain. His respiratory rate is 29, temperature is 35.8. He has a bruise on the scalp and is complaining of neck pain. What triage code will you assign to this patient? Lots of you are saying red. Anybody else out there with another answer? Everyone is saying red. Many of the responses would tag this patient red. Toha Yasin says yellow. Emmanuel says red. Paddy says yellow. Red because neck pain is suspicious of C-spine injury. Interesting. But we'll know the actual answer in a few. So we go to the next case. Amongst the casualties, it's the same case, same case that we had previously, but now of the 9 people in a taxi. But now amongst the casualties is a 43-year-old female. She's approximately 20 weeks pregnant. She's conscious in severe pain, sustained a fracture of the right humerus. Her respiratory rate is 34 breaths per minute. Systolic blood pressure is 80. Her temperature is 34.4. What triage color code will you assign to this patient? Okay, I'm seeing a lot of reds. 43-year-old female, 20 weeks pregnant, conscious in severe pain, has a fracture of the right humerus, respiratory rate is 34, BP is 80, temperature is 34. What triage color code are you going to assign? So Kayongo Michael says red with features of shock. And many of you are assigning the patient a red color code. So we shall go to the next case. Stephen says yellow. So I'll go to the next case. Still the same case, same scenario. Amongst the casualties is a 23-year-old male, oriented, has a deformed lower arm with severe pain. Respiratory rate is 18, systolic BP is 110, temperature is 36.6. What triage color will you assign this patient? Ivan says yellow, Isaac says yellow. Remember, says red. I hope it's for the same scenario.
Yeah.
Amongst the casualties is a 23-year-old male, oriented, deformed lower arm with severe pain. Respiratory rate is 18, systolic BP is 110. Temperature is 36.6. What triage code are you going to give? Joshua Kiria says green. Haggai Wambale says yellow. Nagala Emmanuel says yellow. The chat is really busy. I like that. We are all paying attention. That's nice. You can't even ask a question. Or Andrew Okiro says you can't even ask a question. I unfortunately I don't get. Maybe you can clarify what you mean by that. Kamar Evan, hi. I see you're saying green. Nice. Oh, Andrew Okiro says green. So next case. Amongst the casualties is also a 23-year-old male. 23-year-old male, oriented, deformed lower arm. He has severe pain. His respiratory rate is 18. Systolic BP is 110. What triage code will you assign this patient? Black. Alex says black. Beatrica Peterson says green. All right. So those are our cases for this session. We shall be looking at the answers at the end of this session. So at this point, I'd like to welcome our next experts, quite experienced with MCIs. Over to you, Mr. Nsubuga Daniel.
Thank you very much. Thank you very much, now my colleagues in the room and all those who are following us. This is a very important session. It applies to us. It has several theories, and it has a number of decisions which people make, as we have seen when you are tagging your patients. For sure, we have had several incidents in the country which are on the land. Transport has been mentioned, the buses. We have had fires like the Chigogwa, Namungona fires, which are recent. Those on water, like the MV Templar. Terrorism, like the one which was in Lugogo during World Cup. We also have collapsing buildings. So, a number of mass incidents. But unfortunately, the first responders do not have this knowledge. And it's upon that we lose a number of people who wouldn't have died. In this context, the government has taken initiatives to have more ambulances, to have more technical people. And normally the first ambulance on the scene will be the ambulance of the technical people who have arrived. In our case scenario, it was fortunate that the ambulance was en route and it arrived. It was 3 minutes away. There are several actors. You all know we need safety. The police checkpoint is within the proximity. But what decision would you do? To go and get the traffic to bring them on the scene, or to continue with the scene? And how best will you get there? So while we are outside, and given other discussions and experiences, they are also looking at, actually I'm simplifying what Dr. Daniel had already mentioned into an operational system where we have an over responsibility in the CS cut, CSCA triple T, whereby we shall see what it means. But the aims remain the same: to salvage as many patients as possible using the meager resources, to ensure safety of the responders and safety of the casualties, to optimize utilization of resources so that we don't waste much resources on someone who is in expecting level of priority, and eventually we lose him. He has taken a number of resources. To synchronize the engagement of specialized forces and systems given their capacities, to reduce the response time and the scene clearing time, and lastly, to make effective proximity and appropriate evacuation to the definitive care, the right care. In the case scenario we had, our hospital was the nearest, 16 kilometers. Yet Jinja was 23 kilometers, and it's a regional referral. Amongst those patients, we gave for a scenario of 5 out of 9 could be there are those who would have benefited better if they go to Jinja regional referral, which is far away, and those who can benefit from a general hospital, given its resource and capacity. So the CSCAT approach is looking at a scenario where we have a command and control. A command and control. In future, or in the near future, we shall be getting accustomed to an acronym of a shock room, which means Strategic Health Operation Command Room. And in this command and control, we have 3 tiers. I will talk about them. The S goes for safety. The moment you reach the audience here, the moment you reach at the scene, of course, you have to identify the hazards. It's important that you don't forget that we have the physical and the CBRN. CBRN, which means chemical, biological, radiological, and nuclear. We have communication. This has already been mentioned, but you cannot communicate everywhere, not until when you go back to the strategic command to help you reach the specialized forces. We have assessment to continuously evaluate size, scale, scope, the changing needs at the scene, and en route. But in our assessment, again, we emphasize the maintain. Then we go to the triage. We have talked about the start and salt. But where you are still in a crisis, where people are still in the wreckage, an approach or a step further may be taken to use 2 approaches of a sieve and salt. Where we sieve, from the unsafe area and gather casualties in a CCS, which is Casualty Collection Station. Then we do the treatment. Saving people is not scoop and run. We have to stand play. And the stand play can be best done at the CCS. Then we make priorities of transporting our casualties, depending on how we have coordinated it in an orderly flow, a good evacuation of patient to appropriate receiving facilities. We may consider proximity as number one, where we may get additional resources to support. We may also consider specialization. We may also consider financial implications. In Uganda, we have very many private facilities, which may be within the reach, but not all people have insurance covers, and not everyone may have cash on him to pay for such services. But again, as we prioritize, we who may be at the scene, we should also consider not to cause a surge at the receiving facility. We are solving a problem of mass casualties, but again, we have created mass casualties at A and E wards in the receiving facilities. So in our next slide, we have the chain of command. We have the GORD, which is constituted by senior management at the Ministry of Health and other actors, including the National Incident Commanders. We have the SILVER, which is the tactical. Its role is to make sure that the strategy happens. And it also plays the supervisory and managerial roles. In this opinion, the REX must take up that responsibility of the tactical command. Let's take an example of the incident which was in Kapchora. The REC of Umbali must know the nearby facilities and the resources at those nearby facilities to engage them to respond. He has to escalate to the strategic command. I remember one of the caring doctors saying, if we risk taking these kids to Kampala, they will die because of the stress of the road, which actually is right. But again, at the strategic command, Uganda has the capacity to airlift using choppers from UPDF, UPDAF, and police. We have seen this, more especially where we have mass gatherings. And then the operational command, which is bronze, to the frontline staff at accident and emergency, and those who work in pre-hospital settings. It's a must know. And why in hospital getting involved? Because it will be called upon to go on the ground, and reaching the ground, you must know the approaches. So basically, those are the three levels of the command and control we have. The main thing has already been talked about. We can skip that. And we reach the casualty or the rendezvous, the scene of incident. At this point here, we have different zones. Zone number 1, which is the inner cordon, is where the incident has happened. Be it on the road, be it at a building site, or wherever it can be. It's the role of the first person at the scene to make sure that it cordons properly. You have to set a casualty clearing station, that whoever is removed from the inner cordon goes to the second cordoning, which is governed by the more technical people who may arrive at the scene. In many incidents we have had, police will always arrive first, fire brigade will arrive first. They may not be able to measure the respiratory rates. They may not be well acquainted with the airway, breathing, saturation, and those signs of life and the normal parameters of those signs of life. So here, when we are screening, actually, it's at this point where the sieve starts. And when you are sieving, like the way it was mentioned, you can mention that, please, you introduce, of course, to get the professional authority, the medical team has arrived at the scene. Those who can walk, those who can raise your hands, raise the hands. Those who can walk, walk and come this side. By doing that, you're already sorting. And those who can walk, the walk wounded, automatically become green color because they are oriented. When we use the motor response, when we use the GCS. Those who are oriented and cannot walk, they will constructively go in yellow. But on the other side, you have reduced the number. You have reduced the casualties. When you sieve out the green, assign somebody to take them in a distant place where a secondary triage can be made to sort out others. These people may need one resource, and they also need psychotherapy. For example, a walk wounded may need a pressure bandage to stop bleeding. The yellows who have remained, those must go to the casualty clearing station for the secondary triage, which you are yet to see. You have to create a place where you can load ambulances. To avoid the traffic, you must have an entry point and you must have an exit point. When ambulances arrive at the scene, they have to get a parking area so that if a clinical decision is made and a given ambulance is recommended, for example, type C, then the dispatch officer on the ground will order for type C and they load the patient. If the patient needs a type B, they will do that. If a type A can take 2 or 3, then the priority will be made. So basically, that's the layout of the scene. In the next slide, we can go to the next. It has the command structure, the scene. Remember, if you are the most experienced who arrived at the scene first, you don't do. You take control. You keep your hands off. Because if you get involved into doing, you lock yourself to one casualty or patient, and eventually you lose many. So in this context, you appoint a communication officer who will help you that call this ambulance for that. You appoint an ambulance forward commanding officer, depending on the need. The need could be that among the primary triage, you identify those who have to go straight away. Maybe they need oxygen, and in the care, in the CCS, there is no oxygen.
so they have to leave the scene immediately. You have an ambulance loading point officer. This person must also take the biodata of whoever has been evacuated from the scene. Because where we have mass casualties, the relatives will come and the response teams should be able to tell whoever went to which hospital. By doing that, again, we are saving many hospitals from being overloaded. We can proceed. Selecting the CCS, you can consider a safe distance from all hazards, consider accessible ambulances. It may be a point where vehicles cannot reach, but when you are setting your CCS, make sure that it is within a reach of vehicles. It should be accessible from the evacuation routes, and where need be, it must be sheltered and also screened so that the privacy of people are ensured, because there are those assessments where you have to totally expose. Now we can proceed. I want to skip that red, yellow, and green and black for now, for some reasons, and we put much emphasis on our sieve and SWOT approaches. Let's move on. Okay, we have that chart over there. When you look at it, it has the 4 steps. And I want us to use those 4 steps so that you cross-check your scores as well. Step number 1 is to use the Glasgow Coma scale, GCS. We have eye-opening, which has a score of 4. We have verbal, which has a score of 5. And we have the motor response, which has a score of 6. When you add up together, it will give you 15 out of 15. When you reflect to the case scenarios you had, you must by now know the status. But we shall take 1 or 2 and we conclude it. Step 2 is to convert the GCS. In the tables we have displayed, I is A, verbal is B, and motor is C. So Glasgow is A plus B plus C. But it must be converted. Any patient who will get a score between 13 and 15 is scored 4. You can record 4 somewhere or 3 as per your choice. Anyone who has a score of 9 to 12 is 3, 6 to 8 is 2, 4 to 5 is 1, and of course the least score in the GCS is 3, which is 0. From there we take the respiratory rates. I do assume that we know the normal ranges. But if you are not certain, we can take 10 to 29 so that anyone who has a respiration rate of 10 to 29 gets a score of 4. Anyone who has above 29, he gets a score of 3. Who has hypo, 6 to 9, he gets a score of 2. 1 to 5 gets a score of 1. At the sieve triad, we don't have diagnostic equipment. We don't have BP. But at the CCS, where we have technical people, the BP machines will be there. So we take the BP. Any score which is above 90, he gets 4 of systolic BP. 76 to 89, he gets a 3. 50 to 75 gets a 2. 149 gets a 1. And where we cannot tell it, it can be a 0. So computing this, we go to step 3 and we assign the triage priority. Let's take an example that our GCS gave our patient a number 3 score. We have to add, which is X, we have to add Y, which is a respiration rate. Let's assume that our patient was hyperventilating. He had a 32 or 35 breaths per minute, which is above 29. So he gets a 3. And let's assume that the BP was around the systolic BP is around the 87. So he gets a 3. When we take a 3 plus a 3 plus a 3, we get a 9. That means we match in step 3, where is 9? 9 is below 10, which literally means that our patient will be put in category red. Within red, you may find someone who has a GCS of 4, a breathing rate of 3, and a BP of 4. 4 plus 4, 8 plus 3, 11. Automatically, that one will go in yellow. If you have like a GCS of 3 plus a respiratory rate of 3 plus a BP of 4, that is 10. So in red, you have one who has 10 and another one who has 9. When it comes to priority, again, the one who has 9 may take precedent over the one who has 10. However, if it drops below 6, then we start getting worried that chances of survival are minimal. We may waste time and resources and we lose the person. Yet we would have saved more people if at all we use the same resources. So we have to rethink our priority. However, this is crowned by upgrading our scores, looking at the dependent, the nature of injury or diagnosis you make at the scene. For example, we may have infants. They may cry, which is an equivalent of talking to an adult, but they cannot explain other conditions. Therefore, any below 2 who cannot explain and is crying, we shouldn't assume that given that she's crying, the airway is clear. And we delay. We have to put these ones in red so that further assessment is made and appropriate treatment is given. There is a table which was displayed. Let's try to look at it and see. Is that the rest? Okay, that one. We have 2 scenarios on that slide, which I think I have already explained, where we had the GCS. Eye opening is 3, verbal response, the score is 4, motor response, the score is 3. So if you add up, you get 10. This yes is 10. So this yes of 10, when you convert it, it will give you a 3. So 3 plus respiration rate of 3 plus systolic BP of 3, you get a 9. And constructively, that patient will be a red. Where we have eye opening at 4, which means spontaneous, verbal response at 5, oriented, motor response at 5, which means is not obeying command, but he can appear confused, which will give us a score of 14. When we go to convert 14, we shall get a 4. If the breathing rates are giving us a rate that puts us in 4, systolic BP is giving us a score which puts us at 4. When we add it up, we get a 12, and we go in green. One of the case scenarios we had, one was oriented. They had an injury, but the score algorithm was putting him in green. At that point, probably I can end the submission at that point, and then we also try to focus on answering some of those questions they had put forward. Thank you very much.
Thank you very much, Mr. Nsubuga, for that very excellent and highly informative presentation. You have taken us through incident command system, establishing a command and control, and emphasizing the need to establish great leadership as you're managing your MCI incident and establishing communication channels. And you have gone into helping us understand the SIV triage and how to calculate and attach a triage code for patients or casualties at the MCI scene. Thank you very much for that presentation. At this point, we are going to go into questions, but just to your presentation, just a question. As an expert, a pre-hospital expert, man who has managed MCIs or been part of teams managing MCIs, what common mistakes do first responders make when they are managing these MCIs? I know a couple of people in the chat have been talking about how they know of casualties who have been triaged wrongly and have ended in the wrong place. So what are some of those mistakes you have observed that first responders commit when managing MCI in just a minute?
There are many. And actually one had raised the concern that what can be done to save these patients? One of the common mistakes which is made is the experienced person to stay and act. When you stay and act, you are deprived of giving guidance, which would be ideal. Secondly, responding to mass casualties, we must have a prior planning. And I would like to commend for this matter the Ministry of Health, World Health Organization, and the team which is helping us to come up with the mass gathering management frameworks. This team has tried to look at some of the mass gatherings we have. We have religious mass gatherings. We have Namgongo, of which everyone on this forum knows. We have annual Passovers, night prayer, night whatever, every end of year. And then we have culture-related mass gatherings, where we have Nkuka, where we have Imbalu, and many others. We have sports, mass gatherings like the Kawakas run and very many runs these days. We had the Chan, we shall have AFCOM and many others. We have entertainment, concerts, and we have professional conferences. We even have state organizations and gatherings. So in those points, we may get mass casualties. Depending on the activities they are doing, the age group involved, and the time of the day, whether day or night, things of that kind may happen. So a pre-planning can improve, plan the resources you need, can improve to map out the referral pathways and receiving facilities. Therefore, attending to mass gatherings when you don't know where to refer, when you are not conversant of the resources you need, we end up losing many people. Another factor is that at times we go emotional. You say walk wounded and you are driven by blood. And yet you can tell this person, get a dressing, plug it there as I bring more resources. In other words, this very person can help himself. But when you take more time dressing it, in a certain area, you may lose those who have breathing disorders or airway compromised disorders. So basically, that's what I can say among the common mistakes. And maybe another one which is very important, making a wrong decision of referral. Let's take Kauru Hospital. We have a spine injury in the taxi, and we have Ginger regional referral. Whereas Ginger appeared to be far, I would say, let it go to the regional referral, where they may have more resources. Otherwise, you may refer to General Hospital, and reaching there, they offload the patient, reassess, and they make another referral, which is time wasted. And in emergency, time is a muscle lost. So basically, those are the things we can consider.
Thank you very much. Thank you very much for that submission. At this point, participants, if you have any question regarding the presentations that we have just had, please use the emoji, put your hand up, and we'll be ready to unmute you such that you can pose your question. Or if you want to have any submission or clarification or addition to this discussion. As we wait for anyone to put their hand up, I'd like to pose a question to our expert, Dr. Olinga. I know we have talked a lot about the pre-hospital bit, but what about when patients are being brought to the hospitals, the receiving units? Like we have seen, sometimes the units, the surge capacity is well above and you're overwhelmed. What strategies do you propose for clinicians working in these units to better prepare for these MCIs? Because MCIs do not announce before they occur, they are just sudden. So what strategies do you propose for clinicians to be able to handle such situations?
Interesting, Dr. Rebecca. You know, like you said, we can't anticipate when an MCI occurs. I had not anticipated that I would be put on the spot for this, but yes, I am prepared, and so I will address the question levied unto me with the preparation that we usually have, and so while at the hospital, we have talked about the concept of surge capacity, and that is trying to create more space and recruit more resources in a given facility to try and manage the casualties who have actually walked in to your facility. And so I need to put a disclaimer out there for the audience and people listening in. It's really a good disclaimer that disaster management or mass casualty incident and management is a universal subspecialty. For context, we had an example of a pregnant mother who was part of the casualties. You can have pediatric patients. You can have medical patients with chronic diseases coming in as well. So what does this mean? You're recruiting internal medicine, anesthesia, emergency medicine, surgeons, obs-gyn, all into your hospital. So like I'd highlighted earlier, because we never prepare for this, so we can always have CMEs to alert these different teams that once we have gotten a call about a mass casualty incident and they are coming to our hospital, we are then going to plan to recruit other departments on board. Case in point, surgery and obs-gyn. If they had planned to do elective cases, surgeries or elective obs and gyn cases, this is the time you call that list off and prioritize opening up space for theater. But you're also getting these surgeons and obs-gyn teams on board because they are trained to arrest or achieve hemostasis. You're in the uterus, you cut a certain artery, the obstetrician knows how to do this. So if we're having a trauma patient, we want to salvage these patients as well. So he can actually achieve hemostasis before the definitive care is brought on board. That is one point. The second point is that we have incidences of overcrowding in the hospital. So you have a patient who is chronically on treatment, once daily ceftriaxone. We're having a mass incident. Why don't we then quickly discharge off these patients? They go home, they can always return and get their medications if they're fairly stable enough, so that we create space to actually admit these mass casualty incident patients, while also retaining the resources for these patients to be managed once they come into the hospital. So I close this by saying the best preparation for this incident in the hospital is by deactivating other redundant or non-functioning units, so that you recruit all the resources and workforce and channel it into the mass casualty. Thank you very much.
Thank you so much, Dr. Olinga. We have a question in the chat, which I'll pose to anybody, including you, Mr. Nsubuga, to answer. With increasing road traffic crashes, industrial incidents, and disaster risks in Uganda, do you believe our current emergency response system has the capacity to fully implement the CSCAT principles? If not, what are the three most urgent gaps that policymakers should address? That is from Walusimbi Dennis Wise.
Thank you very much. Towards evidence-wise, I can say that the CSCAT approach, right now, the interagencies are meeting and they are designing the framework. As I had already earlier mentioned, they have tried to look at the potential likely incidents where we may have mass casualties. It is attended by the police, it's attended by the military, by agencies which have an auxiliary role to the healthcare in the country, and it is spearheaded by the Ministry of Health. So in forum of this kind, I think the knowledge is being disseminated, the approach is being standardized, and sooner or later, their works will be disseminated to each and every facility. Then regions will be empowered. In a nutshell, I can say it is in the making, but fast tracking.
Right. Thank you so much, Mr. Nsubuga, for that submission. So at this point, we are going to go through our post-session poll of questions. Question one was, what defines a mass casualty incident? The answer was answer 2, that should be B, number and severity of casualties which exceeds available resources. Question 2, which of the following is not one of the 5 pillars of MCI? 80% of you answered correctly, and the answer is infection control. The next question, what principle guides resource allocation decisions during an MCI? 83% of you got the answer correct. Greatest good for the greatest number. The next question is, in the methane report, what does the H stand for? 86% of you answered hazards, which is correct. So the next question. Yes. So we're going to go through I hope you are all able to see the screen to be able to see which answer is correct. So for the case 1,
Which one, the driver?
yes, for the driver. Yeah. Yeah, you can.
For the case 1, which had the driver, the answer was black. Or is black. Rationale? He had no signs of life, no respiration rates. The BP was not done. He had an head injury, and given that they bumped into a station vehicle, the mechanism of injury and the magnitude may have caused the critical injuries.
Next question.
Next.
The next is for the male of 60?
Yes, 60-year-old male.
The 60-year-old male, whereas he had the pain in the neck, but other parameters and the calculation we have gone through of the SWOT, GCS plus the scores of the SWOT triage, he goes in yellow.
Next question. It's the next case. 43-year-old female. 43-year-old female, 20 weeks pregnant.
And who was pregnant? The BP gives us a score of 4. The breathing rate, high, which is a score of 3. The systolic is 80, which is a score of 3. So 3 plus 3 plus 4?
10.
10. She goes in red. And the additional conditions she has. Yeah.
Next question.
The next question was
2-year-old male. Did this project this question? 2-year-old male who was at the back seat, the mother, with no visible injury, crying, respiratory distress. What color code would you assign the patient?
The color code is red. The means of communication is by crying. She needs additional assessment and is below 2 years.
All right. I hope you have all taken note of that and have checked yourselves to see if you are wrong or correct. I hope you have understood all the answers and the explanations to that. So as we come to the end of our session, I'd like to pose some closing remarks from our experts. I will start with Dr. Olinga to my left in just a minute or 2.
Thank you very much, Rebecca. In as short as time as possible, I just have 2 points that you ought to remember for the MCIs. So one MCI can be approached in 4 phases. So phase 1 is planning and mitigation. Before anything happens, you should already have this structure, and that is what is ongoing right now. We are trying to plan to develop those protocols, and mitigate these things, ensuring that the roads are well protected, the fires are controlled in whatever areas. Then preparedness as well. So preparedness comes with training of the different health workers, the lay responders as well, to not, when the truck of fuel is about to explode, you're seeing fuel and you're running there. So we have to prepare by, handling all those different aspects and getting acquainted with some of these triage tools that we are bringing and the protocols. They seem many, but with the drills, repeated reading and assessing and attending these sessions, you will actually get better. Then phase 3 is the response phase. Of course, now that you've been trained and you definitely will have to be able to respond. And then we always forget about the recovery phase, but this is very important because you have to recover, restock whatever resources were used up so that you prepare for the next event and the phases repeat themselves. And then number 2 is think of an MCI as a stroke patient, the stroke patient being the disaster. So the predisposing factors to stroke, like the hypertension, diabetes, etc. So as we're managing it, think about these factors like the overcrowding that can be in the hospital. Because when an MCI occurs and we're supposed to manage this disaster and we have overcrowding, we may fail to achieve the adequate management. And then 2 is 2 in part, that is aphasia. So one of the commonest features that may occur in a stroke patient is aphasia, failure to express, failure to speak. In an MCI, mass casualty incident, communication is the bedrock. So if you do not communicate appropriately, then we are going to have a break in actually coordinating with different EMS persons, with the treating hospitals. That's aphasia. And then the second feature in the stroke patient that may manifest is asymmetrical weakness. So what do? We tend to run towards one facility and we paralyze that facility. We use up all the resources that are there and it tends to fail. So it becomes asymmetrical weakness. But if we are to break the clot that has caused this stroke, then we have to, plan on time, be prepared, and this involves money and resource availability. Thank you very much.
Thank you very much, Dr. Linga. Over to you, Mr. Nsubuga.
Thank you very much. As we wind up, I would like also to reflect on some questions which were put forward and regard the question of coping strategies. I would say learning experience, because wherever we have mass casualties or incidents, whichever incidents come with a different scene, scenario, situation, but the principle remain the same. So master the principles, address as per the situation and scenario, and not forgetting your safety. It has a lot of burnouts, it has a lot of psychosocial support which is needed. Christina was saying, how do we respond? Of course, we have talked about structure, preparedness plans, and having sessions of this kind, and to frequently run through them, where it may be difficult to develop charts. Reference charts are not a crime to have them to help you get those calculations. Michael was talking about triaging. I think it has been adequately covered. Another simplest way is to look at the resources allocated. The green may need 1 resource, a yellow may need 2 resources. So we have a fracture. We need a splint and a bandage. A red may need 3+ resources. Charles' concern was mentioned. The methane. Chiwa had the something I think to do with the structure and proper triaging which has been done. But I thank this forum. I appreciate Sid Global ECHO for organizing such sessions, because learning is continuous from cradle to day. So in our free time, in your free time, always think about, get mental maps and plan how best you can handle.
Thank you very much, Mr. Nsubuga, and to Mr. Omar, who has been very busy in the chat. answering all questions, closing remarks from you.
One, thank you very much, the participants. I want to recognize the panelists for your expertise. We're really, really proud to have you. But above all, I want to give credit to the people who have been busy down there in the chat. One common thing that is coming out, people are asking, are we really ready? Do you think we can? Someone just asked if at all we could be able to manage areas where we have mass incident of a gas where people have been poisoned. And the answer could be is, what's your expertise? Let's agree that you cannot be everywhere. I know people would love to respond, but also the fact that it is important for you and me to know, what am I good at? What can I do best? The objective is clear. I want to save as many people as we can in the shortest time possible. Your expertise is not needed now. Allow the ones who have already taken on to handle the mantle and come through. Toxicology, very important. Yes, the toxicology champion can actually affirm to this. Two, let's accept train. Let's conduct the drills. Let's give that interest. And above all, we use the established systems. People should do hazard mapping. Let's understand what we have around. Find it hurting when we keep on saying, oh, this RTA in our area. What does your hazard report tell us? Support us, and I am telling you, we have the capacity, we have the best teams around, and then prioritizing the principles of masquerade incident. I thank the people who have been behind theirs, giving us. It is clearly people who are talking about the RTAs. Yes, we've exhaustively explained how best. Someone who was interested in management of gas, training we've talked about, and then people know what's my role in all this. Thank you so much.
Thank you so much, Mr. Umar, for those closing remarks. Important, I've liked the idea of hazard reporting. I hope wherever we are working, we are now going to be more aware of the hazards in our communities or areas of practice. I hope this session has been as enlightening and impactful. And I hope that whatever knowledge you've acquired from this, the different skills that have been highlighted to manage MCIs, I hope you're not going to sit on this knowledge. You're going to go back, you're going to read more, you're going to try and improve, you're going to try and practice. Because like I said, hazards do not announce, they are sudden, they happen. At that point, I'd like to thank our experts, our very experienced experts who have taken time to be here and give us this rich knowledge. I'd also like to thank our hosts, Seed Global Health. These CME's Eco Sessions are brought to you by Seed Global Health in conjunction with the Ministry of Health EMS services. Thank you so much for bringing these sessions to life. As per tradition, I think it's at this point where you all put on your videos. You can put on your videos so that we can take a picture to commemorate this session. Oh, I forgot to thank you, the participants, the attendees, for also taking time to attend this session. It's an investment in yourself, but also an investment in the health of this country and beyond. So thank you so much for attending, and please watch out for any upcoming sessions. And if you know you've missed this session, if you know someone who has missed that session, or you want to revisit that session, these sessions are uploaded on the YouTube channel. I think the link has been shared. I hope all of you have your videos ready and the picture is on. You can now smile. Yeah, camera is on. So I'd like to shout out, I saw some familiar faces, some familiar names. Andrew Okiro, wherever you are, hi. Dr. Kamara, I see Paul Otim, wherever you're joining from, thank you for joining in. Emmanuel Lugoba, thank you for joining in. Edrin, Dennis Okuraja, Apoyo Pamela, wherever you're joining in, thank you. And yeah, that brings us to the end of this session. Thank you all. Thank you all. Have a good evening and stay blessed.